Hello viewers, my name is Vicky Ia and I'm a graduate student in the lab of Dr. Li Ping Tang. Me, along with my colleagues Jakara Smith, Angelica, Tejas, um, uh, worked on this project and I'm just very thankful for your interest in our lab's work. So today we're going to focus on some of the wonderful work being done at UTA on medical devices, specifically the intraocular lens. Now, we know how important vision is to our everyday lives. Unfortunately, as we age, many of us will develop cataracts. So today I'm going to cover how the intraocular lens plays a role in a specific complication after cataracts called PCO, which can cause patients to lose their vision again. I will specifically focus on a high-risk group, people with myopia. So let's get started. PCO, or posterior capsule opacification, is the most common complication after cataract surgery. Now, scientists believe it is caused by the infiltration and growth of lens epithelial cells. That is, all the lens cells that are left over after this traumatic cataract surgery. They're trying to grow and rebuild the lens, and this leads to scar tissue formation. This is bad because it's going to cause our vision to become blurry again. There are also several risk factors for PCO, including young age and high myopia. We'll investigate myopia here. Myopia affects a large portion of the population, actually 25% of us, and an estimated 50% by 2050. More alarmingly, patients with myopia are also more likely to develop PCO than those with normal emmetropic eyes, and this means that the cases of PCO will be rising. So, how can we as engineers design an improved device to combat this issue? There are several design factors that influence PCO incidence, such as material and edge sharpness. Well, it turns out that patients with myopia receive these low-power IOL implants, which are much flatter than the normal lenses. So these IOLs have what are called a high posterior radius of curvature. Well, what we would like to know is if we optimize this IOL curvature, can we achieve a stronger binding between the IOL and the lens capsule, and therefore impede that cell response from happening and developing into PCO? We think we can. Our hypothesis is that with the current IOLs in use for myopia patients, there's a low physical interaction between the IOL and the lens capsule, which leads to higher cell responses and greater PCO incidence. To test this hypothesis, we fabricated a simulated lens capsule, SPLC, that mimics the three-dimensional shape, dimensions, and mechanical properties of the native myopia lens capsule. We also chose some different commercial IOLs of different powers or different curvatures to implant into this model. And with this system, we can do a series of tests. First, we analyze the space between the IOL and the lens capsule, the SPLC, our simulated lens capsule, using a technique called optical coherence tomography. And this allowed us to image a cross-section of that test system and measure that space directly. Next, we wanted to see how well the IOL binded to the lens capsule. So we were able to measure this directly using this custom bending bar apparatus. And lastly, we seeded cells into this testing system and quantified the amount of cells that were able to infiltrate behind that IOL. In terms of our experimental results, they were very much in line with expectations, showing high space between the high PRC IOLs and myopia SPLC, and low space for the low PRC IOLs. The adhesion force results were the inverse of this, right? Low binding force was found for the high PRC IOLs, and high binding force was found for the low PRC IOLs. Since there was more space under those high PRC IOLs, those flat IOLs, there's no surprise that we also observed higher cell infiltration under those high PRC IOLs compared to the low PRC IOLs. In all, our results identified that current low-power IOLs create a significant mismatch with the myopic lens capsule. This led to high interface space, low adhesion, and high cell responses. These results not only provide a mechanistic explanation for high PCO in these myopia patients, but it also points to a key IOL design feature that can be leveraged in future work to improve IOL safety, that IOL-PRC. And in our future work, we plan to design, print, and test different IOL designs to investigate which dimensions may be most suitable for patients with a variety of levels of myopia. In this, we hope to be able to develop IOLs with improved safety and reduce the risk of PCO. Thank you very much for listening, and we look so forward to hearing from you soon.